Good afternoon and welcome to the Immune Deficiency Foundation's SCID Compass Lunch and Learn. Today's program will take a look at 4 years of universal screening for SCID in North Carolina. My name is Emma Mertens and I'm the Program Manager of Community Relations at IDF. On behalf of all of us at the Immune Deficiency Foundation, I'd like to thank you for joining us today for this Lunch and Learn. We are excited to host this webinar for the IDF community. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your journey. Today's Lunch and Learn is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. A brief disclaimer. Please remember the information presented during this forum is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational forum or event. Many of you tuning in today are doing so because you are an individual, parent, caregiver, or friend to someone living with severe combined immunodeficiency or SCID. SCID Compass, an educational program of the Immune Deficiency Foundation, is designed to guide parents of infants diagnosed with SCID, people living with SCID, and the medical community through the journey of learning about this rare, life-threatening medical disorder and find support to navigate the health challenges along the way. SCID Compass is supported by a grant through the Health Resources and Services Administration, or HRSA, which is an agency of the U.S. Department of Health and Human Services. SCID Compass was developed through a partnership between the Immune Deficiency Foundation, RTI International, and the Association of Public Health Laboratories with support from Expecting Health and the SCID Angels for Life Foundation. To learn about SCID and SCID Compass, please explore our website at www.scidcompass.org. The website offers a robust variety of online and printable resources for anyone eager to learn more about this condition or share information with others. Topics cover every step in a family SCID journey from diagnosis to return home and everything in between. It is also available in Spanish, French, German, Portuguese, and Tagalog by clicking on Select a Language in the upper navigation. SCID Compass also offers monthly and annual programming and events. In addition to our monthly Lunch and Learns, we host an annual SCID Summit and support all the great programming that IDF offers to the PI community. This includes forums, Ask IDF, Get Connected groups, and Rare of the Rare. We're also thinking of ways to bring the latest in SCID to you, such as the SCID Compass Summit. We hope you will save the date for this exciting annual event later in the spring, June 23rd and 24th. I would now like to introduce our guest for today. Scott Schoen is the director of the North Carolina State Public Health Laboratory and was instrumental in SCID Compass's early work when the program launched back in 2018. We are thrilled to have him join us today as we take a look at 4 years of screening for SCID in North Carolina and a glimpse at multiplexing for SCID and SMA. Welcome, Scott.
Thank you, Emma. All right. So as Emma mentioned, this is sort of a fun return. I love that this is bite-sized information during Lunch and Learn. It was so rewarding to work when I was working at RTI and partnering with friends at APHL and new friends at IDF to develop SCID Compass and obtain the funding from HRSA for such a critical educational and outreach piece for information that was just, it was at a point with SCID screening where pushing across the finish line all the states to ensure every baby born in the country is screened for SCID, and then learn so much from what has happened over more than a decade now of screening. And I'm going to talk about the 4 years of universal screening for SCID in North Carolina. It's actually, I'll mention this later in my slides, the pilot for SCID in North Carolina started in April of 2017. So it's almost 5 years of since the pilot started. And I'll talk a little bit later, but it's been a good 4 years with a lot learned and a lot of changes in a short period of time. I don't have anything to disclose other than what I just said, which is that I've known Skin Compass from its birth and partnered with many of the individuals at RTI, APHL, and IDF on this project. But I do look forward to sharing a lot about North Carolina and the North Carolina lab that I am so proud to now lead as the Public Health Laboratory Director. So the North Carolina State Laboratory of Public Health is located in Raleigh, North Carolina. For those of you who have been here, we're right across the highway from PNC Arena, where the Carolina Hurricanes play, or the fairgrounds, and near the North Carolina State School of Veterinary Medicine. The North Carolina State Lab, like most public health labs, provide medical and environmental laboratory testing. We also provide certification for other labs in the state, particularly water testing and milk testing labs around the state. And we provide training services to support our local health departments and their local health and their laboratories in the local health departments, the moderate complexity laboratories. We perform, the number changes. It's actually gone up since this slide was made. So, I'll say almost 200 different clinical and environmental tests. And I'm going to talk a little bit about them in a second, but just a robust menu of tests. And again, an old number of 800,000 samples across the lab. Obviously with COVID, that number jumped up substantially. So I think at some point in the last 2 years, we approached 1 million samples every year coming into the lab. And they range from obviously newborn screening, which I'll talk mostly about today, but our blood lead, our environmental lead, well water testing. More than 50% of the homes in North Carolina actually use wells for their water source. In some areas of the state, particularly rural areas of North Carolina, more than 90% of the residents use well water. And so the State Public Health Lab is responsible for testing any new wells, as well as testing any wells that residents are concerned about. We obviously have our emergency preparedness teams for bioterrorism and chemical terrorism. Our infectious disease teams, obviously doing our microbiology, our parasitology, bacteriology, our mycology, our mycobacteriology and tuberculosis work. Within virology, our vaccine preventable diseases, measles, mumps, rubella, HIV, sexually transmitted diseases, COVID. And then a growing molecular epidemiology team focusing on sequencing, pre-pandemic, mostly focused on antibiotic resistance, during the pandemic, variant detection for COVID, and our quality and regulatory compliance teams to make sure we comply with all of our regulatory oversight, whether it's CLIA, FDA, EPA, DEP, DEA, all sorts of acronyms from the federal government that we need to make sure we're compliant with. And then our operations team, we have a fully functioning warehouse and mailroom, as well as our administrative teams, who really are the backbone of the lab. So the non-technical staff who do all the data entry and the results mailing and customer service and security and procurement and everything else that is required to make the public health lab run. So while my story is similar to other public health laboratory directors across the country, clearly I'm most proud of my team here in North Carolina. So really now taking a quick dive right into newborn screening in North Carolina. And I have never given a newborn screening talk without sharing Dr. Susan Tanksley's jelly bean diagram. I actually think this has been revised. It doesn't look like this anymore, but I refuse to let up on the old school version that she created as part of work through the Laboratory Standards Work Group and the Advisory Committee on Heritable Disorders in Newborns and Children. Dr. Tanksley is the Assistant Director for the Texas Public Health Laboratory. And so, I just love this diagram. It shows how complex the newborn screening system is, with the baby in the center and laboratory testing just one part of the program, and one small part of the entire system. And that's really what I think SCID Compass has embraced in support of patients with SCID and families affected by SCID, understanding how complex the system can be. Obviously, within the state of North Carolina, there are many stakeholders, the state laboratory ourselves, our new division of child and family well-being. Our follow-up program actually used to be in the same division as us, the Division of Public Health, and our child and youth branch, but has recently moved to a new division at the department called Child and Family Well-Being. Our partners at UNC Division of Genetics and Metabolism who focus on the metabolic follow-up. So for our mass spec disorders, but also have a role in in the follow-up of other disorders, at least the care of children with other disorders. Clearly, we have linkages, though not direct overlaps, with our EDI and CCHD teams. We have a robust newborn screening advisory committee. We are lucky to have Dr. Joe Munzer, who is an international expert on mucopolysaccharidoses based at UNC, who chairs, and the chair of the advisory committee on heritable disorders in newborns and children, Dr. Cindy Powell, is also on our advisory committee. So we have a great advisory committee here in North Carolina who provides a lot of feedback and guidance to the program moving forward. And we're just so lucky to have so many subject matter experts, whether it's at UNC, Duke, Wake Forest, Atrium Health, just so many wonderful clinicians who help guide the program moving forward. And the list of national partners is too short. I understand that. Obviously, we have our partners at the CDC, Newborn Screening Molecular Biology Branch, clearly instrumental in SCID, which is why I want to mention them first, and getting SCID running here. Our partners at APHL, Julia Jodu and Sika Singh and their whole team in the newborn screening team there. CLSI, talk a little bit more about CLSI. I had the pleasure of serving on the CLSI newborn screening expert panel and working on their new revision to the SCID guidelines. And a whole host of advocacy groups. Clearly IDF is the focus today, and SCID Angels for Life. But whether it's disorder specific advocacy groups, disorder agnostic but rare disease advocacy groups, or other advocacy groups that help support us in our mission to identify children early and get them into care so they can live long and healthy, productive lives and remain largely unaffected with the most severe outcomes of these disorders is critical to the program. What I don't think people realize is North Carolina was a historic leader in newborn screening. I put a little bit of the history on the left-hand side of my screen here. And I wanted to call out two specific parts of the newborn screening history and newborn screening and our contributions to the system. We weren't the first state to begin screening for PKU. That happened a year before we began. But UNC Chapel Hill actually developed a quantitative method for the detection of PKU, which had been identified qualitatively prior to that. So an initial sort of quality improvement initiative on PKU screening early on in newborn screening's history developed here at UNC Chapel Hill. But I think what is by far one of the most profound and paradigm shifting technologies for newborn screening was the introduction of tandem mass spectrometry. And that was developed at Duke University. And Dr. David Millington was a colleague and now a good friend, an advisor to the program who helped develop that at Duke University in North Carolina. Piloted tandem mass spectrometry and newborn screening beginning in June 1997 and became the first state to launch what was called expanded newborn screening using tandem mass spectrometry in April of 1999. So really cementing North Carolina as a leader historically in newborn screening. The tale of SCID would tell otherwise. It took our state a bit of time after SCID was added to the RUSP before we added it. I'll talk a little bit about that and the challenges there. But a lot of the lessons learned and how moving forward with the new disorders that are added to the RUSP put newborn screening in North Carolina in a better position to more rapidly get these tests onboarded and begin to impact lives. Before I talk specifically about newborn screening, about SCID newborn screening, I'll finish up my discussion of our general newborn screening process in its total. We screen about 120,000 newborns annually. I think it's actually getting closer to 125,000 at this point. People keep moving here. I did. Came from New Jersey down to North Carolina, but my kids were born in Jersey. But a lot of people come into North Carolina, so our birth rate is strong. A total of about 130,000 samples for those 120,000 babies. As of Monday, we will be screening for all the core conditions on the RUSP except Pompe and MPS I. We're launching screening for X-linked adrenal leukodystrophy on Monday, and Pompe and MPS I are following quickly behind. So we'll have more news on that. No dates to announce on those, but again, running the entire full current RUSP panel. On the left-hand side of your screen, I have pictures across the entire part of the screen, but our program is broken down into three main testing areas. We have our immunoassays and hemoglobinopathy or sickle cell identification. We have our tandem mass spectrometry, we have our molecular team. So over on the left-hand side of the screen is our immunoassays. So we use the PerkinElmer GSP, and we use the Astoria Pacific Spot Check to test for a whole host of biochemical disorders, whether it's galactosemia, biotinidase deficiency, congenital hypothyroidism, congenital adrenal hyperplasia, cystic fibrosis. We use the HPLC and isoelectric focusing to look for hemoglobinopathies. In our tandem mass spectrometry unit, we just transitioned from our Waters TQDs to the new QSIDE instruments for our routine amino acid and acyl-carnitine testing. And we are doing first-tier X-linked adrenal leukodystrophy testing on these instruments, and also have installed the AD-SciX triple quads, blanking on what model we have, but two fun instruments to do second-tier X-linked adrenal leukodystrophy to start, and to expand our capabilities and capacity moving forward. So really great advancements in our tandem mass spectrometry work. And then finally, our molecular team, which is growing and expanding. We use the Illumina platform to do cystic fibrosis variant detection, the CFTR mutation analysis. And then we transitioned to the Quant Studios to do when we multiplex SCID with SMA in May of last year. So I'll talk a little bit about that moving forward. And real quick, some recent data, 2019, 2020, just some basic stats of cases, confirmed cases by disorder. You can see we have identified some cases of classic SCID in the last couple of years in North Carolina. Data is still being pulled together. And I was working with our follow-up team to try to get 2021 on the slides. Have a little bit of that later, more specifically about severe combined immunodeficiency. But obviously during the pandemic, our data systems and data modernization came into play and really taxing where we're going. Obviously, I think everybody who's on this call and involved in SCID is thrilled by this picture, a wonderful map from our partners at New Steps, showing that every state and every territory in the United States is currently requiring universal screening for severe combined immune deficiency. A long road from the 2010 addition to the RUSP, but it is great to see and so proud to also have North Carolina blue on this map. And so, this is a 4-year recap, but I'm going to go back further. I need to talk about, in general, the history of SCID screening, particularly in North Carolina. I mentioned several times in my talk so far that January of 2010 was when the Advisory Committee on Heritable Disorders in Newborns and Children, that wasn't the name back then, I guess it was SACADUNC back then, voted to recommend that SCID be added to the RUSP. The letter was sent to Secretary Sebelius in February, but I actually did go back to the minutes and saw that the vote and the meeting happened in January. The secretary accepted that recommendation and added SCID to the RUSP in May of 2010. Less than a year later, the North Carolina Newborn Screening Advisory Panel voted to add SCID to the North Carolina Newborn Screening Panel, made a formal recommendation to the program. And then in October of 2015, there was North Carolina legislation called the Baby Carly Nugent Bill. Carly had SCID. Her mom, Stephanie, campaigned for this bill to require the addition of SCID to the state's newborn screening panel, and that was signed into law in October of 2015. And IDF and Marcia Dimes were very instrumental in the work there. I'm going to focus quickly, though, on the time between 2011 and 2015 when the law was passed, because there was a lot going on in this red starred area at the State Laboratory of Public Health and in the newborn screening program that was setting us up to move towards the addition, and some challenges that developed, some bottlenecks and some opportunities that we've learned from moving forward. So first and foremost, the entire state public health laboratory relocated to a new facility where I sit today over 2012 to 2013. And anyone who has moved a house, much less a laboratory, knows how disruptive that can be. I participated in a move in my prior work in another state, and it is quite an undertaking to assure continuity of testing and quality at all times. And so that was obviously a major disruptor to progress on any front, because during the move, you're just trying to maintain your current capacity and your current capabilities, much less taking on new things. So that was one of the challenges that happened in that time frame from the recommendation to the law mandating the addition. There were also several asks of the legislature to increase the fee for newborn screening in North Carolina that were unsuccessful. That is a story well told in many states across the country in sort of the early 2010s, where increasing fee was frowned upon, but everybody wanted to expand panels. And so it was this opposing forces of needing funds to hire and build out new instruments, particularly in SCID, because SCID was a whole new foray of going into molecular. There had been small advances in molecular newborn screening, but really this was the first primary first tier test that was going to use genetic markers to identify babies at risk. And so not only did we not have the technology, but we didn't have the people trained to do the technology. And so you were having to shift from microbiologists who originally did PKU to biochemists who were learning mass spec to now molecular biologists. So it was real paradigm changing at time in the field of newborn screening, including here in North Carolina. To help buoy the program in the absence of a fee increase, the state lab received external funding from two sources. First, in September of 2014, APHL provided funding for the expansion of SCID, and there were many funders many funding sources through that program. APHL New Steps put out a wonderful summary of those activities and a report on that experience. That's the picture you see on the right. You can find that on APHL and New Steps website. And the story of North Carolina is in there, not specifically, but a shared challenges that were overcome to get SCID screening up and running. And then in September of 2015, CDC, North Carolina State Laboratory of Public Health actually partnered with RTI early on. So this was even before SCID Compass. RTI and the state lab have had an exceptional partnership and collaboration to advance a number of activities, not only newborn screening, but we partner in other areas and take advantage of the robust expertise at RTI. But in newborn screening, CDC awarded a grant to RTI International, who was collaborating with us to get SCID screening up and running. And I mentioned the challenges that were that all public health labs face and all newborn screening programs face bringing this on. I mentioned the newborn screening, the new instrumentation and methodology challenges, but also then the education and follow-up. We had to bring in a whole new group of specialists, immunologists, right? So historically, you had metabolic geneticists, we had endocrinologists, we had pulmonologists, we had hematologists. Now we had to bring in immunologists and a specialized immunology team, not just allergists, which I think many states faced. Obviously allergy and immunology are linked, but this was a very different paradigm. And I know I'm preaching to the choir through the team at IDF and SCID Angels for Life and everybody else who might be on the call, but that was really a challenge to get that up and running. And I've said a couple times, fees, right? Just getting enough funding in place to make the program capable of expansion. So I mentioned these dates a little earlier. The North Carolina program started the race to implementation before, obviously with the funding, but the pilot began April 24th, 2017, so almost 5 years ago. And the pilot was designed to help refine the method, to help define the follow-up algorithm in the state, and to assure that the system was in place. Obviously, we had world-renowned experts locally. Dr. Rebecca Buckley's at Duke, but we have, as I said, experts at Duke, at UNC, Wake Forest Baptist, Atrium Carolinas Medical Center. So a variety of specialists around the state. I've left some out, and I apologize if they're not happy with me, but I do know who they are. I'm just blanking on them all at the moment. But making sure that the system was in place, that jelly bean diagram I showed on my second slide was there for the families who are going to be identified of being increased risk for an immune deficiency. And so the way the pilot worked in North Carolina in 2017 was normal results were not reported, but babies who had an abnormal screening result were reported verbally through a follow-up program. And again, this was just to make sure everything could work in the lab and outside of the lab. And then December 4th of 2017, later that year, was the official launch of SCID screening, reporting all results on the newborn screening laboratory report and having everything in place. So we crossed that finish line a little over almost, a little over 7 years, almost 8 years after the vote. But I'm really proud that we got there. And again, learned a lot of lessons along the way. So I'm going to get a little lab geeky for a moment. I apologize for that, but it helps me tell the story. And after all, I'm a lab director, so that's my lane. This is a wonderful picture that I found on CDC's website. Dr. Francis Lee has used this in many of his talks that I've seen. And this was sort of this decision-making process of how are you actually going to screen for SCID early on. There were two pathways, this on-card method. Some historically called it an in situ method, but it really wasn't. This on-card method where you just punch the dried blood spot into wells, you wash them several times, the genetic material, the DNA stays on the spot, and then you just add the chemicals, the PCR reagents, and then amplify, and you get these beautiful amplification plots, these curves that you see in the bottom right-hand side of the screen, where the earlier amplification are what you see in babies with a normally functioning immune system. Those next curves where you see almost a delayed signal could be either a baby with SCID or some other immune deficiency, some other variant immune deficiency. I'll talk about other diagnoses that we've seen here in North Carolina later on. And then a complete absence, or typically what we see with classic SCID, is no measurable detection at all. So the heart of the newborn screening test is you're looking for the absence of something, not the presence of an increased metabolite or something like that. The other side of the coin here, or the path, is to actually, instead of just leaving the spot in the well, you extract the DNA from the spot and then amplify the genetic material from that extraction. Why am I going into this level of detail? Because initially, North Carolina, like many states, used the on-card method. It was quick. It was easier. I won't say it was easy. Nothing in this process is easy, but it was easier. And it helped with throughput, and we were able to automate it. You see the Beckman Bauer robot that we have a couple of here in North Carolina, and the original Agilent PCR instruments that were used through this on-card method. And so it worked very well. But part of my talk, as Emma said, was going to discuss our transition to the addition of multiplex with SMA. And we realized that we needed to shift from that on-card method to an extraction method, which had its challenges and caused us to have to change several things, good and bad, right? I mean, it gave us the opportunity to reflect on 3 years of screening and make changes. While we're changing the method, we might as well look at our interpretation and make other changes, but also forced us to make changes that we might not have wanted to make. And so that I'll talk a little bit about in the next couple of slides. And so a lot of the initial work through the funding that I mentioned earlier with APHL, and then through the CDC funding through RTI, was done with in partnership with my colleague, Dr. Jennifer Taylor, who is now at ACMG, who used to be at RTI. And some of the work she did, she obviously worked with Bob Vogt and Francis Lee at CDC in her fellowship before coming to RTI. And so I'm showing some of her data here on the top left. And she was very instrumental in a lot of the work that the state lab then transitioned here for population-based newborn screening. And it was originally done by birth weight. So, there was this decision point that programs had to have of, are we looking at baby's birth weight? Are we looking at gestational age? That will come into play, foreshadowing in a couple slides. But you see the population distribution here from the validation that was done, and this trail off of cycle threshold with a fewer number of babies trailing off here. And so again, the interpretation was determined by birth weight. And this was an original flow chart of the run, where a baby with a cycle threshold of 31.6 was negative, greater than or equal to 31.6, or again, no measurable amplification of the genetic material. These TRECs would require a retest, and then reporting out as either negative, so normal, borderline. In a borderline scenario, we just ask for a repeat to be sent in. Something is amiss, but it's not really indicative of an immune deficiency, just not clearly normal result. And then obviously our abnormals, which would reflect immediately to a clinical follow-up for flow cytometry. And I'll talk about some of the other diagnostic workup that happens at our clinicians. And then an inconclusive would be perhaps a bad sample. So if a sample is collected poorly initially, Again, the transition to, we have a molecular test that's affected by some other chemicals such as heparin. We identified a large number of hospitals that were using heparinized tubes to collect blood from heels as opposed to allowing the bloods to drop right onto the filter paper, and those caused false positive results. So there was that learning curve as well and education at the hospital level. So this was just the beginning of SCID screening in North Carolina. I'm going to show data at the end in terms of what we found and talk about the challenges, because we transitioned from that path and that work for 3 years to then adding in SMA for now almost a year. Due to the same types of data modernization challenges that we've seen during the pandemic that have affected COVID and the way we capture data, we are facing a lot of that here in North Carolina and improving our data systems and working with additional funding to partner with RTI and others to improve our data management systems so that we can better parse this out. So I'll share some challenges and some overarching themes on data analysis moving forward. But again, SCID SMA, we maintain the same biorobot, though they are reaching a near end of life, and so we'll be looking to replace those shortly. But we transitioned from those Agilent instruments to the Thermo Fisher instrument you see here, the Quant Studio. And again, as I mentioned on my prior slide, moved away from this on-card method to this extraction method. So, from a regulatory standpoint, when you change method, you have to validate this, and it has to be validated in accordance with CLIA, which is the Center for Medicare and Medicaid Services oversight of clinical labs. But instead of just doing this sort of transition to a new method, we completely just blew up our path and realized we were going to set all new cutoffs. We were going to look at our algorithm in general, because we learned, as so many states have learned, that these preemies and these tiny babies, these micro preemies who are in the NICU for extended periods of time, cause such havoc on screening for SCID, because their little bodies just don't have a robust white blood cell count to give us that accurate data. And so it causes a lot of noise in the SCID screening system. And so we wanted to take lessons learned from 3 years of doing that, as well as our colleagues around the country, to make some improvements. And so we shifted our path moving forward. And so here's some great data from our validation. So up on top is, again, the data that I said came from Jennifer Taylor's work before the launch of SCID screening in 2017 in North Carolina. And on the bottom is some work that we did with Kay Chow, who was a public health scientist here at the state lab for a little while, as she validated the multiplex of TREC with SMN1, or the marker for SMA. I don't know if you've noticed, but I'll point out, in the process of changing everything, we said, you know what, let's transition away from birth weight to use gestational age. We had been collecting gestational age on the cards, but hadn't made a formal transition to using it in our interpretation. Most states had found that it was a reliable demographic variable and actually resulted in a more normal curve than using birth weight. So it allowed the statistics of screening to be a little simpler for us. But as you can see, those full termers, which we defined at about 37 weeks on this graph, really had different results from those preemies, with a real, sort of right skewed data for these preemies, with a lot more babies having higher cycle thresholds, again, just because they were tiny and they were born early. So this allowed us to do a real deep data dive. We ran thousands of samples as we prepared for this transition to the new method in multiplexing with SCID, with SMA, to really take a look at what are best practices across the board. And I know this looks complex compared to the flow chart I showed before, and it is, but it's elegantly complex. And it allows our team to really visualize what are we looking at in terms of TRECs, in terms of our quality control markers with RNase-P, and incorporating that gestational age of, are we going to follow up these babies? Because again, we had a lot of noise in preemies, and we were causing so much work on our follow-up team and our clinicians to follow up babies who ultimately were perfectly fine, or who unfortunately passed due to their micropreemie status and their other systematic issues. that we worked with our specialists and our pediatric immunologists to identify, what is truly a baby at risk and what is sort of a demographic or issue related to the baby, him or herself. And so we went to a scenario where even if a result was abnormal, we just requested a repeat until the baby got older. And we call this sort of an adjusted gestational age. So if baby came out at week 30, we would say in 5 weeks, send us a new sample. The caveat to that was if we had no detectable TREX at all, if there was no evidence that this baby had an immune system, we would call that baby out right away. Many states, and I've had experience with this in my prior work in newborn screening in another state where we had a preemie who had no TREX, who was somewhat delayed in diagnosis because it was written off as just being a preemie. And so we can see a clear line of babies with low TREX versus no TREX in that preemie population and built that into our system. We also took a path of, we didn't lose birth weight altogether because sometimes the hospitals don't fill in gestational age, even though it's a required field. But they will fill in birth weight. So we've used a surrogate on birth weight of 2,300 grams to allow us to make some determinations. So we're not holding up getting babies into follow-up. So again, more complex based on more knowledge, but again, elegant and allowed us to build it into our limb system. So it's not as much thinking on the technical side as it is automated evaluation. So babies who have an abnormal screen or who are borderline multiple times receive a referral to immunology within 48 hours of that result to get clinical evaluation and diagnostic testing. I'm not a clinician. I am a lab geek. So there are things that have been added to the diagnostic testing platform that I have not captured here that I know are captured well in the upcoming CLSI revision. But a complete blood counts, flow cytometry with a defined panel, mitogen testing to really understand how the immune system is functioning. And then our immunologists interpret all the diagnostic results and direct further management, whether it's what therapeutics or whether it's transplant or other workups must be done to move that baby forward in terms of a follow-up pathway. I've mentioned SMA. I know this is an immunology talk and SCID Compass, but I just wanted to show the work that we did with SMA to get SMA running. And a very similar idea and interpretation. We don't see the same issues with preemies because of the nature of what we measure for SMA, as opposed to using TREX and white blood cells. We're using an endogenous marker, this SMN1 gene, and specifically exon 7 in SMN1 to identify babies with that deletion for SMA. And so SMA screening has been going quite well. We started May 1st of last year. We have already identified 5 babies with SMA in North Carolina who have gone on to various different therapeutics, whether it was gene therapy or the intrathecal injections of biolog that name is escaping me at the moment, but SMA screening is off to a very robust and successful start. And I will say that unlike the challenges with SCID early on, with new technology and new expertise necessary, we had all of that. And so SMA has benefited from the trail that the SCID community blazed to get running in newborn screening. It was a lot easier to get SMA running than it would have been if there was no SCID before it. So I think kudos to all the work that was done to get SMA running and get molecular programs running more robustly to get SMA running. I know that was a definite opportunity in North Carolina. I'm going to skip through this. This is just our reports and what we say. Again, we have a immunodeficiency screen and a premature infant comment. So that's something new that we didn't have before. And I'll land on my last 2 slides with some data. I realize that I don't have any data labels. So I apologize for this being less useful than maybe you would like it to be, but we have some proportions here. And I think what's really telling on the first 2 columns is what I've been saying about preemies. So those, when you build the preemies in, you can see how many normal results there are. I believe there's about 60 or 62 normal results for everybody over the last several years. And half of those were preemies that just had repeated tests or had to be followed up. All of our classic SCID were in our full-term population. That actually is it. Oh yeah, so this is everybody. So the three we're all in the preemie, we're in the non-preemie population. And then a whole host of other diagnoses you see here in our abnormal callouts, as well as our borderline and our repeat borderline areas. And our 4 major medical centers that are identified by our follow-up brochure. I mentioned them throughout the talk. But other diagnoses that we've seen that are quite common in newborn screening programs that catch all idiopathic T-cell lymphopenia, which I know many groups, including SCID Compass, are looking at trying to better define and help us work through from a screening perspective. Syndromes with immunodeficiency associated with it as well here. We actually found an MPS 7 baby who had an abnormal, we don't screen for MPS 7, but the baby had an abnormal immunodeficiency screen. And obviously to George, and then PGM3 deficiency. So a variety of other diagnoses that come about. Obviously, severe combined immunodeficiencies is the core condition. Other immunodeficiencies due to T-cell lymphopenia is a secondary condition. So any baby that has low T cells or no T cells is going to be picked up no matter what is causing that diagnostic result. And so this is our wall of saved babies. This is an old picture. This is hanging outside our newborn screening lab to remind our team the impact they have on the families in North Carolina. This is actually a picture from 2018 that shows through 2017 data. So I desperately need to get a new slide. But every time a baby is confirmed with one of the conditions on our panel, they get added to the clothesline, and then what you see are, we don't see socks, but socks are an individual baby, and then jammies or something else are like 5 babies. So it's just a really great reminder of the impact that our team has, and very rewarding to remind the team, particularly in challenging times, why we do what we do. So what's next? What's next in general? I've been talking about CLSI throughout. CLSI is working on a revised guideline. The original guideline was released in April of 2013. So it'll be almost 10 years. So it's time, and so many new things we've learned, whether it's how we screen or therapeutics for SCID and related immunodeficiencies. So can't wait to get that in our hands. We continue to work with our partners to refine our cutoffs and look at our results and revise our interpretation. And those partners include our clinicians, but also our data partners I've mentioned throughout. There's this constant drumbeat of B-cell immunodeficiencies and expanding to look at CREX. Who knows what the future holds there, but we'll be ready if that's where we go. And then a lot of genetics on SCID and next-gen sequencing, and what could that bear out. And so we're just really thinking about how to position ourselves to pivot to any new developments on those fronts. Elsewhere in North Carolina's newborn screening, I mentioned XALD goes live on Monday. The rest of our lysosomal storage disorders that are on the RUSP, Pompe and MPS 1, are coming up this year. So we're very excited about having a full RUSP panel running in North Carolina. We are ready for any new RUSP conditions that come up. For those of you who aren't aware, tomorrow the advisory committee is voting on whether or not to recommend MPS 2 for the RUSP. So that's clear and present. And GAMP deficiency is also on the agenda for the advisory committee this year. So a lot going on at the national level. And I mentioned data modernization. So really piggybacking on all the modernization in infectious diseases, looking to expand our LIMS, our laboratory information management system, our case management system, to really assure that we're looking at our data routinely and using it to make data-driven decisions. I think as many times as I say data-driven decisions, I could say it better, and really assure that we are doing best for our constituents, our stakeholders in newborn screening in our state and elsewhere. And so I leave you with my contact information, and I did not have an acknowledgement slide, but obviously I do want to thank everybody I mentioned so far. Our team here, Assistant Director Dr. Dee Pettit, our amazing program manager, Kimberly Blake, who has been on the job for just about a year and has added SMA, gotten us in a new LIMS, adding XALD, on the path to Pompe and MPS 1. 6 new mass specs, 8 new mass specs, including 6 for primary and the 2 for secondary, a new gas generation system, upgrading our molecular technology, a new GSP, just so many advancements in newborn screening the last year here in North Carolina. We are so super excited about the future, and her entire team, our partners at RTI, our partners at APHL and CI International, just an amazing group to work with, and thrilled to move forward. And thank you so much to SCID Compass for allowing me to come back and provide a 45-minute bite-sized talk for my presentation today.
Wonderful. Well, thank you so much, Scott, for sharing your wealth of knowledge with the IDF and SCID communities. That talk was incredible. We really appreciate you putting together the presentation and taking the time today. So thank you so much. And now we are going to open it up for some Q&A. So it looks like we have a couple questions already. All right, our first question. Would you say that the challenges you've experienced with screening SCID beyond your lab move are unique to North Carolina in your protocols/processes, or more universal at labs throughout the US?
So, I would say they're universal, right? I mean, that's the work that APHL has been doing, SCID Compass. It's founded on that these are universal challenges that programs have faced. And I think most of the challenges of getting, not even most, all the challenges of getting SCID screening running have been overcome, because as I showed the map, every baby born in the United States, in a state in the United States or territory, are screened for SCID right now. So we've overcome the challenges of implementation. Now it's making it the best program it can be by using data analytics to evaluate that. I think the challenges go beyond just using data. We're having challenges in public health at retaining staff, and keeping up with revisions in equipment as things get sunsetted and having to validate, and all regulatory challenges. So those are not unique to North Carolina by any stretch of the imagination. These are issues that many states face. There are great resources. I'll give a plug for a historic program at CDC that I think has been put on hold because of the pandemic, which are the MAP visits, the molecular assessment program visits. I loved working with Suzanne and Francis and the team there on the MAP visit, Chris Green on the MAP visits. Just great opportunities to look at and see that these are universal challenges. And while they don't have one solution, because each program is unique in our own way, there are a subset of solutions. And I think everybody's working towards identifying what are those menu of solutions so that everybody doesn't have to recreate the wheel in our state.
Wonderful, thank you. All right, and our next question is, how many false positives for SCID do you see per year?
The short answer is too many. One of the things when I joined the program, when I became lab director here at the end of 2019, right before the pandemic hit, was I have a personal passion and love for newborn screening. It's been most of my public health career. Looking at our performance and just saying that we're just calling out too many babies, because there's an inherent fear, I think, of missing a baby. And so a lot of programs skew too far to capture, they cast too broad of a net. Clearly we don't want to miss anybody, right? But the reality is screening is screening, and biochemistry and genetics are different. And we do our best to capture everybody, but we might miss somebody. The problem is that we can't flood the system with too many false positives. And so the answer to the question is, right now it's too many. I don't have an exact number to tell you, but the percentage is in the high double digits, like incredibly high double digits. We're not going to get it as good as SMA. SMA is it's a different biomarker and it's crystal clear. I mentioned we had 5 babies with SMA. We've only called out 5 babies for testing, for diagnostic testing. So we're 100%, right? And most states are 100% on SMA because it's a different marker. So we won't get there with SCID because TREX and the way the white blood cells function and the biology of the cells we're looking at, but we need to get better. And it starts by looking at our data. And it starts by having a system that allows us to look at our data. So that's where we're going in North Carolina and learning lessons from other states who have already done that. So, I think, and I'll just finish by saying it's critical that we do hone in on our tests and make sure our false positives are low, because as we add conditions, we're adding more work to an already strained system. So our clinicians and our follow-up teams need to know that there's good reliability in these results and that action is critical, because the worst thing we can say is, oh, it's another false positive. And that can't happen. So.
Awesome. Well, thank you so much again, Scott, for this wonderful presentation. We really enjoyed having you today.
My pleasure.
All right, so to our audience, if you have additional questions, you can ask IDF. Go online and submit your questions to Ask IDF at www.primaryimmune.org/ask-IDF, or give us a call. We hope you'll remember to take advantage of all of the resources SCID Compass has to offer. We want to draw your attention to a couple today, because we know we have lots of our friends at the public labs on the call today. So first, we want to draw your attention to our SCID fact sheet. You may remember we sent this out to all of our lab partners last spring, and we now offer two versions, one tailored to parents and one for providers. So the goal with this is that newborn screening follow-up contacts can actually share this resource with parents facing the possibility of a SCID diagnosis after receiving the results of their newborn screening. And we even have the option for the fact sheet to be customized with your state logo and contact information. So please let us know if that's something you're interested in. We can make that happen. Oh, we also want to draw your attention to our brand new toolkit for parents, which actually encompasses all of the resources and information found on our website, and a printable, easy to read guidebook, which parents can bring with them to medical appointments or share with family members who want to know more about SCID. So we hope you'll check out both of those resources. Before we close, we want to remind you that all IDF programming is guided by the individuals and families we serve. Many of the topics we explore through SCID Compass are applicable to the PI community as a whole, and all are welcome to learn with us throughout this event series. Please take a moment to scan the code on your screen and take our very brief program evaluation survey, and this will also be emailed to you after the program. Lastly, we hope you will join us for the next SCID Compass Lunch and Learn, where we take a look at SCID and family planning with Brianne Miller, Program Manager of Newborn Screening Initiatives at Expecting Health, on March 23rd. Thank you again to everyone who joined us today for this program. Have a wonderful rest of your day. Take care.